Our next speaker is Dr. Mazen Noureddin, who's the director of the Fatty Liver Center at Cedars, and he's going to be going over an important abstract from AASLD on fatty liver.
That's a podium. Good morning, microphone. Good morning, people. I don't see a screen. I don't see Zoom. Great. So I woke up this morning. I got ready. I got dressed in the bathroom, to be honest, because my wife, 3 years old, and 7 months old were sleeping. I started sneaking out and opened the door, and my wife was like, "You cannot do that anymore." And I'm like, "What?" She was like, "You need to wear regular pants for your talk." So anyways, we'll try to do this in 25 minutes. There were a lot of NASH talks and abstracts in this meeting. So I'm sorry if I missed anything. So let's get started. That was absolutely beautiful lecture for hepatitis B, and wish me luck for advancing the slides. Those are my disclosures. So the objective of my talks today is to talk to you about the abstracts. I broke them as usual for this audience in Southern California: clinically relevant, natural history, diagnostics, and therapeutics. So those are the breakdowns. There were talks about genetics, cost, and the role of NITs in shaping the natural history. For diagnostics, we're going to talk about consortia. The big word now is AI, combination therapy, and therapeutics. You got the vibe from this meeting that there were a lot of losers. Indeed, in my opinion, there were a lot of success. But let's take a look at that, and I'll let you decide. Let's talk about the abstracts on the natural history. Zubair Younasi, as usual, he did a great job. This time, he looked at the burden of the disease and broke the natural history by NASH with obesity and NASH without obesity, and they stratified them by age. And in the left, you will see, as expected, NASH with obesity had increase in all cause of mortalities, and that increased by age. If you look at the right side, that even did cost more, NASH obesity compared to non-obesity, and they increased by age. And if you look at the red, you see the sign in $1 billion, which is quite scary. So another way to risk stratify things and look at the cost, and for insurance and payer to look at things. That was an oral, and it was an outstanding abstract. There's a project in the VA called the 1 Million Veteran Program, focused on genetics mainly. And what these people, or these authors did, they took advantage of that Million Veteran Program, and they looked at NAFLD. The way they did this, they did it by ALT definition, which was the best way they could. And they did 2 ALT elevation to define NAFLD. They ruled out other causes, and they ended up with 90,000 patients, which is a lot. Not the best way to define NAFLD, but this is a lot of patients, 90,000. And they had a control of 128,000 patients. So they wanted to look at the genetics in this large cohort. To have some confidence, they had a validation cohort from biopsy-proven patients of 7,000 and radiology-proven NAFLD cohort of 44,000 patients. So the bottom line is they looked at the old SNPs and new SNPs, and this is the new SNPs that they ended up with. The names might not mean much to you, but the bottom line is there are new SNPs that are being discovered, and the field of genetics in NAFLD is still being discovered, and it still needs to be applied clinically. So I thought the next 2 abstracts were outstanding. Why so? Because the non-invasive testing continue to shape the role of natural history. And why this is crucial? Because the FDA and the regulators need to see that non-invasive test is as good as the biopsy in predicting outcomes. And this is when they will throw the liver biopsy and tell us use a fibroscan or MR elastography to determine outcomes. And in this study that came from Japan in a longitudinal follow-up, what they showed here, in MR elastography, it depends on the degree of stiffness and divided it by 3 categories here, like moderate stiffness between 3 and 4.7, up to cirrhosis. And if you go 4.7 and higher, which is cirrhosis, the higher the stiffness you go, the more likely to get clinical liver outcomes. So that was an evidence that the stiffer your liver, the more likely you get outcomes. Similar biopsy, the higher stage you go, the more likely you get outcomes. Also, they looked at cardiac outcomes, which, as you know, in NASH is very important. And they had the same thing, except when they reached to the 5.5 stiffness kPa on MRE, that started dipping a little bit. So they were not sure why is that, and they hypothesized that because in cirrhosis, HDL and LDL started getting better, and maybe they don't get as many cardiac events. They still have to prove it in subsequent study. Another study from a single center looked at the same thing using MRE, and they found the same thing, especially in this category between 3.6 and 5 kPa, and you need to start getting familiarized with these numbers, and when it's more than 5, they had more clinical events. Also, they combined this MRE with FIB4 in a score that already published in GOT called the MAFIB score, and that MAFIB score also predicted clinical liver events. So it's showing you this combination of non-invasive testing NITs can predict outcomes. So a very great step to show that NITs can predict outcomes. And you see here this mid-range increases the clinical liver events by 16.7%, and if it's more than 5, up to 25%. Shifting gears in the natural history in the last two abstracts to special population cohort. So, and this is a children abstract, 822 children with biopsy-proven NAFLD. They looked at the genetics and the SNPs, PNLP3, you already heard about it, so it showed in the children, but it correlated with steatosis and inflammation. It did not correlate with fibrosis so much. What correlated with fibrosis in children is this SNP, PIARVP. So important finding in children to kind of define the natural history in them, and that was one of the selected abstracts by Best in the AASLD. Dr. Price looked at HIV cohort in women and calculated the FAST score on them. For those that they don't know the FAST score, it's your transient elastography or FibroScan. It looks at the steatosis, plus the stiffness, plus AST. You plug all of them in one formula, and what it does, it looks at those that they have NASH and F2 and higher. So this score predicts who has clinically significant NASH. So what she did here, she calculated the score, and what she found that HIV by itself or black race are risk factors for clinically significant NASH. So that was a large cohort that predicted clinically significant NASH based on this FAST score. Tell me if I'm going fast, I'll slow down. Moving on to the diagnostics. There's data from a big consortia that came out. There's AI cohorts, and there's combo cohorts. I put some slides to remind you. Some of them actually came from the postgraduate course, just to set the stage. So NAFLD is the disease, with the D is the big umbrella. You go back to NAFLD, simple steatosis, what you used to call it back in the days. You progress to NASH, and then look at this box. This is what we focus on in our studies, NASH F2 and 3 and higher. Why NASH F2 and 3 and higher? Because retrospective data show that patients with NASH F2 and 3 and higher are at highest risk for morbidity and mortality. Those are the inclusion patients in clinical trials. Those are the focus. I want to invite you to read a paper in the New England Journal that came from the NASH CRN last month, focusing more on the F3s at higher risk for outcomes. Still, we have to start from the F2 to prevent progression. But again, this is the group that we focus on. And that's why all our non-invasive testing focus on NASH and F2 and higher. NASH and cirrhosis is a different beast, much harder to treat, as you know, because cirrhotics are very challenging. Also, I want to remind you of the primary endpoints of the FDA. You either in phase 3, not phase 2, which is the registry trial, which tells you your drug is approved, you either need to hit NASH resolution, which is NASH score consists of steatosis, inflammation, and ballooning, 8 points. Needs to very much resolve, or you get fibrosis improvement by 1 point, 3 go to 2. If you hit one of them, you get approved, your drug conditional approved. Of course, if you hit both, you will get both of them approved. So this is the NIMBLE consortium, which is in collaboration with the NASH CRN, looked to validate non-invasive testing. And that was presented, I think, as a late breaker. So what this consortium did prospectively wanted to validate the best biomarker we know out there. And those were NIS4, which is a biomarker consists of macroglobulins and hemoglobin A1C. OWL is a metabolomic marker, looks for NASH. NIS look for NASH and fibrosis. And the last three are fibrosis biomarker. ELF is going to come in the market next year. ProC3 is still in research, is a fibrosis marker. And Fibrometer is by the FibroScan company, which is a fibrosis serum biomarker, along with their fibrosis marker, and look for fibrosis. And look what they found. The NIS4 had an area under the curve better than the FIB4. Again, this is for both NASH and fibrosis. OWL is metabolomic one, looks for NASH, had high sensitivity and specificity, and those were the fibrosis marker. FIB4 still does very good. So look at the area under the curve for F2 and F3 and F4 compared to the fibrosis marker, ELF, ProC3, and VCT and Fibrometer. They also did very well, ELF and Fibrometer, better than the FIB4, but ProC3, not so much. This is the data that we presented as oral. The MASH score is similar to the FAST score, but instead of using FibroScan, we use MRI. This is already published in Journal of Hepatology last month or this month, and we use PDFF plus a model elastography plus AST, looking at the same concept, NASH and F2. And what we did in this abstract, we looked to validate that in the Madrigal phase 3 study with resmetirom, a drug, more than 2,000 patients. And basically what this slide is showing you, if you use the lower cutoff, you get most of your F2 and F3 patients correctly, and if you use the higher cutoff, you exclude the ineligible patients correctly. But what we also did here, they have an open label on resmetirom. What we did, we looked at the MASH score to predict treatment response. And if you look here, it predicts treatment response nicely at week 16 and at week 52 on all patients. And if we use our specific cutoff, it actually even predicted it better. And here, this is a better way to show it. So the MASH score in this abstract, moving from predicting in patients of NASH and F2 and higher to predict longitudinal response to therapy, which is like A1C. It predicts your severity of response as well as response to therapy, and that's what you need in biomarkers in general. Moving on to artificial intelligence technologies. There were a lot of abstracts. We're going to see that a lot in medicine. This is an abstract from the Mayo Clinic. And again, we're still looking at the same thing, NASH and F2 and higher. So they try to look at the NASH and F2 and higher using clinical parameters. And if those sound foreign to you, random forest, XGBoost, and all that, those are AI models. And with this model, they achieved area under the curve of 0.95 just by using clinical parameters. No biopsy, no imaging. The problem with this abstract is when you present a model, you should show NPV, PPV, sensitivity, and specificity, which has not been shown in that abstract. Of note, if you have an AA model, you need at least 1,000 patients to show that, and they had nicely that in this abstract. We actually did also have from our group AI model, and not just looked for NASH and F2, which I show you here down. We looked for for F2, F3, and F4, and NASH and F2. And the same random forest model in AI, we had high 0.8 in most of them, and our model did not include histology, did not include any imaging, and that's just like clinical parameters. You plug it into the computer, and you can predict your patients via computers. So in the future, we'll have websites to predict these patients. If you guess those are water snake that are colorful, that's not quite correct. This is actually a biopsy using AI technology. And this is the concept. So those are cirrhotic patients from a study called the Galactin study, which is a phase 2 NASH cirrhotic trial. And the concept is the following. We used AI here. 10 years ago, Dr. Garcia Tsao, she said, cirrhotic patients, we look at fibrosis improvement, and we look at linear improvement by one stage. And this is not making quite sense because cirrhosis is not that simple. there are other architecture features that we need to look at. For instance, the nodule size, the thickness of the septa, and the fibrosis area. So what we did here, we looked at that using AI technology. Dr. Zach Goodman, well-known pathologist, looked at that we partnered with AI histology, and we looked at these features, and we coupled that with AI histology, and we created scores to measure that and correlate that with portal pressure. And look how it correlated with blood pressure, with portal pressures. So it had excellent area under the curves to correlate, to predict portal pressures, clinically significant portal pressure, as well as varices. So it's just another way that we can replace non-invasive testings with AI technologies and look at them carefully. This is an abstract from Arun Sanyal from the Novartis group using also AI technology. So instead of looking just at the fibrosis linearly, what they did in this Novartis study, they looked at fibrosis improvement, not by just looking at from 3 to 2, rather just the septas thickness and improvement in that. So another way is AI that can look at things beyond the conventional liver biopsy methods. Let's move to the therapeutics. In my eye, there were a lot of successful stories. Of course, there were unsuccessful stories. That's the nature of drug development. This is the reminder of drug development. You have drugs that target de novo lipogenesis. You have drugs that target lipotoxicity, inflammation, and fibrosis, or systemic improvement, such as the GLP-1s. So I put 2 slides from the postgraduate course. This is just a reminder of the drugs that are currently in phase 3. Those are for the F2 and F3, and the next slides are for cirrhosis. So the drugs that are in F2 and F3 are those drugs, Aramco, resmetirom, obeticholic acid, and I don't want to talk about story today. It's on hold for approval. Semaglutide and lanifibranol. These 2 drugs came out in the New England Journal this year, so you can read about those. Those are the current cirrhotic trials. Also, this is from the postgraduate course, obeticholic acid, belapectin, aldafermin, efruxifermin, and the triple therapy by Novo and Gilead together. So let's see what was presented in this meeting. The real half-empty abstracts that they were presented are the following. Pegobilfermin is FGF21, and this is the study that was presented in the phase 3 study that was in the stage 3 fibrosis, and that was an oral abstract. This is a 48-week study. The biopsy was done at 24. There were MRI-PDFF as well as a model histography. There were 4 groups, placebo, 10 milligram, 20, and 40 milligram. This is the primary outcome here on the left. I mentioned the primary outcomes in phase 2B and 3 studies to you. They decided that they would go for 1-stage fibrosis improvement. They did not hit that. There was improvement initially in the MR-PDFF at week 24. They did not see that at week 48. MR elastography improved at the end of the study, was not statistically significant. The fate of this drug, that they're not going to continue with the development. They had a poster for cirrhotics. As you would imagine, if it didn't work on F3, it didn't work on the F4. And the Falcon 1 and the Falcon 2 studies are negative studies, and the drug is not going to be carried forward. The next drug, I will let you decide if it's the glass is half full, half empty. Most people consider this as half empty. So this is the aldafermin, another FGF, and those are the placebo, aldafermin 0.3 milligram, 1 milligram, and 3 milligram, and this was 24-week study. They had a lot of positive results in previous studies, and that was 24-week studies. The inclusion criteria was biopsy proven, was NASH more than 4, and F2 and F3 studies, and MRI-PDFF more than 8. They had to have biopsy and PDFF at enrollment and at the end. So let's look at the results. Well, they decided to go, instead of going this or that, NASH resolution or fibrosis improvement, they did predetermine that their primary outcome is fibrosis improvement. They did not hit that. So that was not statistically significant, the fibrosis improvement. Well, look at the NASH resolution, which was not the primary endpoint. They put it as secondary. They did hit that, 22% in the highest dose compared to the placebo, 18% in the lower dose, and that was statistically significant. This is the caveat. This is an injectable drugs. In this same year, we have a New England Journal paper showing NASH resolution with semaglutide of 59%, a drug that can cause weight loss and has good cardiovascular protective profile. So the question is, if they got intimidated by these results, that's the story around the block. They decided not to go forward with this drug. They actually also hit both endpoints at very low level, and they decided this drug is not efficacious enough. Again, they did not hit the primary endpoint, a good reason for them not to continue, and this drug is not going to be continued in development. Indeed, if you look at their non-invasive testing, they hit many of them. Liver fat content, MRI-PDFF by 30%, ALT, AST, and many other biomarkers were there, but they are not moving forward. Let's look at the glass half full. So this is Bio 89, another FGF19. This is a study that was presented before, but this is a pool analysis from their 1A and 2B. So they took multiple cohorts, they pulled analysis and the placebo, and what they did here is it's a unique concept that they wanted to look at the spleen volume, and many of us see patients, and although they are not cirrhotics, we see this larger spleen here and there in NAFL patients, and we all wonder is because the liver is larger, there's more blood flow to the liver, and maybe it's pushing back on the spleen and it's larger. So I have seen it in my patients. We need more publication on that. But what they did here, they did analysis, and what they found with this drug, that there's a reduction in the spleen volume at day 50 and at day 92 on the drug compared to the placebo. And this reduction in spleen volume correlated with MRI-PDFF, the fat reduction in the liver, as well as liver fat volume reduction. So that was a unique finding, and they proposed that maybe spleen volume reduction is an important finding that we need to look at in conjunction with liver fat volume and MRI-PDFF. So you will see that spleen volume coming in the future. TERN 101 is an FXR receptor from the newer generation. This was first phase 2A study of clinically suspected NASH. Some patient had liver biopsy, about just 23 patients, and this placebo, 5 milligram, 10 milligram, and 15 milligram in a 12-week study. They had MRI-PDFF and CT1, which is, as you know, detect inflammation and fat in the liver. So the primary endpoint was looking at efficacy, and the drug overall looked safe. And I want to jump to itching with FXRs, and the itching was very low compared to other FXRs, so that was good news for them. What they achieved actually is change in the multiparametric CT1 signal. It dropped nicely at week 6 and continued to be significant at week 12, and that was statistically significant. MRI-PDFF also dropped week 6, continued to be low at week 12, but was not statistically significant. Then look at the CT1. You have this more than 8 milliseconds that is considered therapeutic and correlates with histology. So most patients were under that threshold, meaning they achieved it and they were beyond it, and it was kind of clinical signal for them that the drug is correlating with histology in this group. So this drug for them seemed to be effective. This is a drug that is going to be combined in their pipeline with a TH-beta receptor in subsequent studies. Moving on to another drug presented by Arun Sanyal. This is a GLP-1 glucagon combined drug, Kudetudide, that is actually already published in the type 2 diabetes literature. It's being compared a lot with liraglutide in the type 2 diabetes literature, kind of same A1C drop and same weight loss. So this is 300 microgram placebo, 600 microgram and placebo. Those were all biopsy-proven NASH patients from F1 to F3. They had MRI-PDFF, and that study was a 20-week study. The primary endpoint was safety. There were a lot of AEs in that study. They are deemed to be mild. It was not too clear to me how much nausea and vomiting in that study. Neither in the Q&A session was too obvious, but the study was efficacious. The absolute reduction in fat fraction and the relative reduction in fat fraction was good, and MRI-PDFF. ALT and AST reduction were good as well, using GLP and glucagon combined, which is not surprising. Liver volume decreased and liver fat volume decreased. The last study is presented by Stephen Harrison, and this is combined a salt drug with also the oxalic acid. This is already published in Nature Communication, and there was 3-arm placebo, 500 BID and 1,000 BID, an 18-week study, and the primary outcome was MRI safety as well as MRI-PDFF. And you see here nice reduction. This is the absolute reduction in MRI-PDFF, and this is the relative reduction in MRI-PDFF by week 18. There was reduction in weight as well as ALT and other enzymes, and it was deemed that the reduction in PDFF and liver enzymes was not related to weight. This is my talk. Thank you very much. Hopefully we'll get to NASH cure as did the hepatitis C folks. Thank you.
Well, that was fantastic, Mazen. Thank you so much.